Thank you so much for coming here, for participating to this session. We want to kick off right on time because we have a lot of things to discuss and share with you. The session is called From Innovation to Reality, the Impact of Cre8 EVO technology on complex PCI. My task is to set up really the stage, first with a short intro and thereafter a very short talk. But the stage is really belonging to the case presenters and hopefully to you, because we want to hear from you and discuss with you what could and should have done. The three presenters as well as three discussants are Professor Han from Korea, Dr. Colangelo from Italy, and Maud Ali Rosley from Malaysia. As always, we have a chat master, which is probably in the room the most important person, because through him, who is Adesh Istvan, you can let us hear your voice, either typing your question, typing your comments, or otherwise, don't be shy, just take one microphone and let us hear your voice without digital technologies. I'm going to give a very short intro, as I was telling you before, and then we go straight into the three cases presentation, and afterwards, as usual, I will be closing the session. This is the objectives of today's session, to discuss technical and clinical challenges of treating complex PCI and complex patients. We will try to define them, which is not easy. And also we will discuss which tools, treatment modalities is needed to optimize peri-procedure and long-term outcomes in this patient, as well as we would like to put the technology into perspective, and namely to discuss how Cre8 EVO can actually offer unique opportunity and treatment modalities. This is just a very short recap of the technology that we are trying to put in the landscape. It's a very well-known stance, hopefully, to many of you. It is unique, and truly I am underlying unique for multiple features. These are four important bullet points. First, it is an abluminal reservoir technology, and unlike many other DS in the business here, it's the only one offering this opportunity. The drug is eluted in a controlled way thanks to a so-called amphibious formulation, which is a combination of sirolimus and fatty acid, which is in a way controlling the release of the drug, which is key, of course, to control instantaneous hyperplasia over time, as well as control vessel injury. But also the fact that it is combined with the fatty acid gives this sirolimus a possibility to permeate the diabetic cells, and therefore having more intracellular concentration, which is probably the reason why this technology is unique in patients with diabetes mellitus. It is carbon-coated, and we know from the valve world what carbon-coated means and the role in terms of passivation from coagulation. And finally, the architecture of the stent is quite unique because the conformation of the event arc stent structure, allowing easy access to side branches. Unique also in the way that this stent offers two markers at the proximal and distal edge. This is a unique stent doing so. And last but not least, it allows a very uniform distribution of the drug, as well as you can postulate the stent as much as you want. The stent will not compress itself. Now, you will be hearing my voice again in the second talk, but I promise I will be short because the stage has to be for you and for our presenter. So I'm not going to discuss, in fact, how to manage complex PCI patients, because that is what we will be discussing all together later on. I just would like to make a few points on what complex PCI means. And my point is going to be very short because we have no clear idea about complex PCI. Antonio Colombo, Gennaro Giustino, and I, together with other colleagues, put together some years ago one of their very first definition of complex PCI. We decided to stick to one of these very easily addressable procedural factor, if you will, are listed here. As long as one was fulfilled, that was in a way fulfilling the complex PCI situation. This definition has been used many times in many papers, including the guidelines. But of course, it's not a very comprehensive definition. It's a very simplified definition. So the UK friends came up some years ago with the formal score, which is very comprehensive, as shown here. It has the advantage of also including clinical features which we did not include before. We will see if and how much that new definition will be used. Meanwhile, what makes things a bit complicated, studies are running using their own definition of complex PCI. I'm going to name only one, yet it's an important one. It's PROTECT 4, where the definition of complex PCI or chip procedure is again another one. The SKY group came together and proposed another definition of complex PCI. Again, this is extremely comprehensive, as you see here, based on anatomy, comorbidities, equipment. And of course, everything is right, but everything is also difficult to be remembered and used in practice. So complex PCI means also complex to define. That's basically what I am trying to tell you. And in fact, if we ask you, we could do that later on, but if you use this published paper about what the practitioners think about complex PCI, what are the features which are identifying a complex PCI situation, you see that basically everyone has her own taste. Probably the most frequently employed feature is depressed ejection fraction. But then if you go through all these criteria, you see that everything is true. And basically each of us has his own perception, her own perception about complexity. Among them, for sure, we have diabetes. This is a very generic slide. You don't even see a reference in this slide because I don't need to reference this slide. Every time we do a study on coronary intervention in patients with diabetic versus non-diabetic, we see in a very consistent way the same picture. Patients with diabetes actually have a worse outcome than patients without diabetes, and we would like to discuss, in fact, how this outcome could be potentially improved, taking into account the fact that we are most likely cardiologists in this room. Surgery as a class 1 indication for revasc, we have a class 2 indication for revasc. Another enemy, it's for sure calcification, detection, and perhaps most importantly, management. We are going to discuss that extensively. We have 4 established tools to manage calcification: orbital atherectomy, rotablation, scoring/cutting balloons. Sometimes they are clustered together, as I'm doing here. Sometimes they should not be clustered together. That's perhaps a topic that we would need to discuss. And lastly, recently available technology, which is actually helping us out, which is intravascular lithotripsy. We'll be discussing a lot about bifurcation, and we'll be discussing how the outcome of a bifurcation procedure can be improved, either by imaging or functional assessment. Now, since we also want to discuss complex patients, not only complex procedure, I would like to close off by mentioning the fact that patients may be at high risk for bleeding. The Academic Research Consortium came together some years ago and proposed some easily identifiable markers of risk, which are basically yes or no markers, including age, for example, or creatinine clearance, so renal dysfunction, if you will, easy to remember, perhaps not very comprehensive, because of course, if you take a continuous variable in a dichotomous way into account, so such as age according to a specific cutoff, or renal disease according to a specific cutoff, or prior bleeding according to whether there were recent bleeding or not very recent bleeding, that of course it's a limitation in itself. And that's why the guidelines are still advocating the possible use of scores to identify bleeding risk. Now, nobody knows what is ideal, but for sure, if you combine these two approaches together, there is a value. Because in fact these two approaches do not always tell you the same story, and you may misclassify the risk of a given individual patient by using one score versus the other. Again, I'm not telling you what you should be doing, what is best, simply what can be done. And the reason why I'm saying this is because bleeding risk adds risk on top of PCI complexity on its own, as it has been shown in this very nice paper. So the bleeding and ischemic risk sometimes get together, and that's why we need to discuss them together, which of course makes our life a little bit more difficult. We want to hear your opinion. We have a chat master, but don't be shy. We have a lot of microphones in the room, and I'm going to handing over microphones to you if you just raise your hand. So with that said, it's my privilege to call upon the first case presenter, Professor Han, to give us his case presentation. Meanwhile, I'll launch your presentation.
Thank you, Chairman. Good afternoon, everyone. I'm Ju Han from Samsung Medical Center, Seoul, Korea. These are my disclosures. A 79-year-old male patient presented with resting chest pain and dyspnea. He was small, 154 centimeter and 49 kilogram. He had diabetes and chronic liver disease. ECG showed ST depression in multiple layers, and cardiac enzyme gradually increased. We performed coronary angiography. ICA showed no significant abnormality. However, circumflex had a very tight stenosis, subocclusive lesions at the proximal portion involving ostium, and another lesion was noted in the proximal LAD, also involving LAD ostium. So this is left main equivalent to bifurcation disease, Medina class 0, 1, 1, 1. And in the middle and distal LAD, there was intermediate lesions. So how would you treat him? There are several points to discuss. The first one is CABG versus PCI. If we do PCI, how should we treat him?
Thank you, Professor Han. Why don't we open very quickly the discussion in the room here? Who wants to add some comments? Raise hands, let us know. Meanwhile, I'm going to ask Salvatore, what would you treat, how would you treat this patient? CABG or PCI? And if PCI, you tackle this tough anatomy?
Yes, the bifurcation is really a 1-1-1 Medina classification, and probably there is space for cabbage, but in our experience, this patient probably with acute coronary syndrome go to PCI, and in case of with this bifurcation, with this angle of these two major vessel, probably I will treat with a two-stent technique, and from the two-stent technique, probably I would choose the culotte technique.
Okay, very important comment. Do you agree or disagree?
Well, I suppose it depends on the patient. I usually discuss this prior to doing an angiogram on engaging their whether they want to do they are veering towards angioplasty or PCI. And in this case, if it's PCI, I think it's going to be a two-stent strategy, because you can see that both the left main and the circ is diseased, and it's quite a long lesion. My preference would be a DK crush for a number of reasons. Number one, you don't lose wire, and therefore you don't have to cross, and if there's a dissection, you may have difficulty crossing, so you maintain blood vessel. Secondly, you can use DK crush in whatever angle, whether it's less than 70 or more than 70 degrees. Thirdly, data has supported it in left main. And number four is probably because I'm quite used to DK crush, so that's going to be my procedure of choice.
Go ahead.
Just two thoughts to this case. Can we get the angio back for a second? With the term of cabbage, so I'm not a surgeon myself, but I work in a place where we do have surgeons. First of all, they are very reluctant to operate anybody with an acute coronary syndrome, which is truly as the case that we see right here. And on the part of the circ, there is no one big obtuse marginal branch that is fit for a graft. So the only one I see is pretty distal, which may or may not be accessible to the surgeon. So I do not think that this is a case for surgery at all. In terms of the bifurcation stent, I'm somewhere in between. I think both the DK crush and the culotte are absolutely acceptable. The thing is, which you yourself are more comfortable with, and the one you have more experience with. Because if you do a DK crush stenting and you have no idea, or let's maybe put it this way, you're not an expert in all the 12 steps that come after each other, and you get mixed up somewhere in a potential patient like this, that can be fatal. Thank you. So please, anybody has a question, I'm really keen to have a look.
Why don't we go ahead? Meanwhile, Professor Han, we see what you did.
Yeah. Regarding surgical risk, STS score was quite high. So for isolated cavity, the operator mortality was estimated to be 20.6%. On the contrary, syntax score was only 12, low, and in the syntax score 2 system, the 4-year mortality with the PCI was 10.6%, and with CABG was 14.5%. So in this case, CABG and PCI both are would be acceptable, but I did PCI. And as everybody commented, I treated this patient with the elective two-stent technique because Circ has quite large myocardium to supply and a very tight stenosis. And regarding technique, what is important is to optimize a stent or a technique rather than the strategy itself, technique itself. So in this case, I chose culotte, just my preference. The one other thing to consider is the Circ first to LAD first. So what is your opinion?
Who wants to answer? So this patient in Lugano would be operated by surgeon, so I don't have to answer it. So you can go ahead if you want.
To me, probably I would start with the LAD because the tight stenosis was worse in the LAD for sure, and later on I go to the Circ. This for me is a codominant vessel because it's very large marginal. It's suboccluded, there is a TIMI-flow 1, but there is a very large marginal branch, and then there is other posterolateral. So I perform before at the beginning the dilation of the LAD with the wire and the Circ, and then go forward with the Circ.
Yeah, that's a good point. I think the LAD first is a good option, but in this case, I treated Circ first. So in our Korean bifurcation registry data of about 700 patients treated with the two-stent technique, the clinical outcomes of MV first strategy and side branch first strategy quite similar during long-term follow-up. However, in the subgroup analysis, when the side branch diameter stenosis was greater than main vessel diameter stenosis, side branch treat first was better than the main vessel first treatment strategy. Of course, it was an observational study and the subgroup analysis, so caution was needed. But in this case, I treated Circ first. The next topic is intravascular imaging. So we don't need intravascular imaging, or we have to do intravascular imaging?
Every time that you perform a left main PCI, you need, for me, it's IVUS or RCT or imaging is mandatory, for sure.
And that's at least what we say at Congress, is that we don't use it ever, but it's okay. You can go ahead and show what you did, because we are running out of time. Yes.
So in the Renovate complex PCI that was conducted by our group, the angiographic guided PCI was a superior, image-guided PCI was superior to compared to angiography-guided PCI in complex coronary lesions. And in subgroup analysis, the most benefit was observed in CTO as well as unprotected left main. And in left main lesions, usually I do IVUS, but in the recent October trial, OCT-guided PCI was superior to the angiography-guided PCI in bifurcation lesions, including left main, about 11%. So in this case, OCT can be tried. And the most important thing is the choice of stent type. So due to time limit, I move.
Please.
Yeah. So actually, the contemporary DS are quite good. So you can choose any kind of DS. But in this particular case, Cre8 EVO is an excellent option because Cre8 EVO has cell design for easy side branch access. So cell shape is rectangular, and the maximum cell expansion for side branch is quite good. And the another thing is foreshortening was minimal, so allowing the use of a large balloon for post-dilation, especially in left main. And one of my favorite thing is it has radiopaque markers, so it allows the exact position of stenting and post-dilation. And we have to comment the clinical outcomes. In the sugar trial, Cre8 EVO beat Resolute Onyx stent, one of the representative DS, in 1,175 patients with DM. So 1 year target lesion failure rate was 7.2% versus 10.9%. Based on these results, I chose the Cre8 EVO stent. Let me show the treatment process briefly. The circ predilation was done, and the LAD predilation was done. After that, the OCT was done. This was pullback images for circ. After OM, the lesion was observed, a very tight stenosis from proximal circ to the ostium, and in left main there was minimal lesions. This was pullback images from LAD. LAD has a quite diffuse disease from mid LAD through proximal LAD. Dissection was observed due to ballooning. So I performed further predilation for lesion preparation, and I implanted one Cre8 EVO 3.5 by 26 from left main to proximal circ. And the stent balloon was slightly pulled back, and the maximal pressure was done. After post-dilation for left main, so I tried to cross guide wire to LAD. Firstly, the crossing site was too close to the left circ, so I moved the position, and the wire easily crossed the stent strap. And after that, balloon was performed, and another Cre8 EVO 3.0 by 14 was implanted from LAD, from left main to proximal LAD. And POT was performed in left main. You can see the marker, so allowing the proper exact position of post-dilation balloon. It is very convenient. And wire recrossing to the circ, and circumflex balloon, LAD balloon, and the final kissing balloon was done. This is OCT images from circ. After OM, distal edge was observed without any major problems. The opposition was good, and the expansion was acceptable. The MLA was observed at the circles 7.9. But in the left main and bifurcation site, there is some malposition. So I did post dilation again using larger balloon. This is OCT images from LED. So, distillation is okay. Opposition was good, and expansion was acceptable. And in left main, stent strut was quite well expanded opposite. These are wires, so stent strut was well expanded. And this was a 3D OCT images. Stent struts over side branches, circumflex was widely opened, a little bit rectangular shape. So I was happy with that. And this was a final angiography. So, stent expansion was acceptable in angiography and OCT, and there was no major complication. So in summary, I did PCI for patients with left main disease, surgical risk high, but the anatomical complexity is relatively low. I chose elective two-stent technique culotte under imaging guidance, and the Cre8 EVO is an excellent option for left main bifurcation disease due to easy side branch access, no foreshortening, and radio-opaque markers, especially in patients with diabetes mellitus. Thank you for your attention.
Thank you very much, Professor Han. It was a wonderful case demonstration how the stent can actually be conformed very well to this very large and complex bifurcation anatomy, but also a very useful case that is showing how important it is to do intravascular imaging, in this case OCT, because you really chased strand malposition as much as you could. So a few comments from our side, at least I kick off. I'm not a culotte fan, so I would have been more on the decay crash side of the equation here. Yet I did not resist the temptation to see that your culotte was a peculiar culotte. So the stent left main circumflex was in a way very short in the distal left main. And the question is it because you have stent markers that you can afford doing so? I would have been more liberal in coming proximal to the left main. Is it because you have stent markers doing this?
I try to pull back left circumflex stent minimally into the left main, and I can do it with other stent, but with the Cre8 EVO, it is much convenient due to markers.
Which is a great point, because of course we have a stent boost, but of course we don't keep using stent boost every time. It has also time and radiation issue. So another comment that I need to ask you, because you are the DAPT expert, is you have a diabetic patient undergoing culotte stent implantation, a lot of metal at the end of the day. So what would be your DAPT regimen, and does the stent choice affect that answer?
Yeah. In ISARECT 5 trial, prasugrel beat ticagrelor in ACS patients, but in this patient, the body weight was less than 60 kilograms, so I chose DAPT with aspirin plus ticagrelor. But this patient had HBR, old age, chronic liver disease, anemia, and decreased platelet count. So after 3 months of DAPT, I discontinued the aspirin and I continued ticagrelor monotherapy.
Wonderful. Any burning question from the audience? We have a shy audience here. There is
Very
no reason
shy,
to be
I'm afraid, yes.
Okay, let's see whether we can revitalize a bit the audience with the second case. Thank you very much, Professor Han.
Thank you.
It's my privilege to ask Salvatore Colangelo now to present a very interesting second case for the discussion. And now I'm going to go around with the microphone, so please ask questions.
So I have my presentation, okay. First of all, let me thank Alvi Medica for the kind invitation. My role is to present a case of a PCI in tortuous and difficult to access coronary arteries. This is my disclosure. And the patient characteristics is a female of 73 years old with many risk factors, active smoker, obesity, high blood pressure, hypercholesterolemia, diabetic, and family history of CAD that in September 2022 developed angina CC2. And the echo performed showed a preserved ejection fraction 59 with inferior hypokinesia. And considering the risk profile and the wall motion abnormalities, a coronary angiogram was scheduled electively. This is the angiogram in November 2022. Right radial access, 5 French, because we had inability to cross with the 7 French, with the 6 French. This is the left with not so much disease, but the right is a very calcified and tortuous vessel with lesion, with the calcified lesion in the proximal part and also in the mid and at the crux. So, how would you treat? Switch to femoral access in this patient, this obese patient, balloon or device preparation of the lesion, and if device-based, which device? Intravascular lithotripsy, rotational atherectomy, orbital atherectomy, laser.
Thank you, Salvatore. Let's quickly discuss. If you have comments, please let us hear your voice. Professor Hahn, would you stick to a 5 French guiding catheter here, or would you upscale? And if so,
I prefer 6 or 7 French in this case. So, if I were the operator, I switch it to femoral access. And regarding guiding catheter, implants may be one option, but in this case, XV 3.0 or EBU 3.5 for Korean patients would be a very good option. It supplies very good, strong backup without safety issues.
So EBU for the light, you mean? EBU for the right coronary arteries.
Yeah. But one size smaller.
Okay. Yeah.
Oh.
And please see the angiogram again.
Sorry.
Go back. Let us see the angio. So it's pretty much calcified and tortuous. So I would probably do the same. I would not stick to a 5 French guide. You need to be very self-confident operator to stick to a 5 French to tackle this.
Yeah, the calcification is severe, but I think we can try the ballooning first. But if balloon is not crossed or dilation is not adequate, I would like to do rotablator, because IVL or orbital atherectomy is unavailable in Korea.
Yeah, great point. Also, RCA proximal part is horizontal, so you will not be able to dip intubate much. So you will need to have a passive backup here. Salvatore, let's go straight ahead on what you did.
Okay. In this case, the operator was so tired in the late evening, so we start to with a setup with the 5 French radial access with the AL1 5 French guiding, and this is the crossing. We use a microcatheter with a CTO wires dedicated to, in this case, to cross this tortuous and very tight lesion of the mid part. And this is the real-time crossing of the SUO 03, the wire that I use in this case. And when I reach the crux, I perform a tip injection from the microcatheter to be sure that I am in the right position and where are the large vessel that I need to cross. This is the right real-time crossing of the SUO into the PL branch. After that, we advance the microcatheter and we switch the SUO with a soft, very stiff wire, but there is no way to go down with just a balloon, even after the insertion of the extra support wire. So at this point, we use a 5 French guiding catheter extension to continue this procedure. And on this guiding catheter, we advance a 2 10 millimeter, so semi-compliant balloon, and 2.5 20 millimeter non-compliant balloon. And at this point, we need to stent. Which stent? And do we have one stent better than the others to choose in case of guiding catheter extension use? Probably the answer is yes. And the stent are different, and the difference comes to the ability of the stent to cross into the guiding catheter extension without any damage. And the minimum lumen diameter of the guiding catheter extension is a foreshortening when it crosses along the tortuous vessel. And this reduction into a tortuous vessel is the higher, the most is the acute band of the guiding catheter to cross and to do in this coronary. In this table, you can see that all the sample that we use in this test had a foreshortening of up to or more than 20% of reduction of minimum lumen diameter. And the ability of the stent at this point is to limiting the effect of scratching and abrasion along the inner surface of guiding catheter extension, because there is an interaction between the stent and the guiding catheter extension. And there is, at this point, the stents are different because, as you can see in this slide, we compare the Cre8 EVO with the three most the ES used worldwide, and you can appreciate how much is the damage of the polymer in the three other stents, from 50% to 25%, and while how the Cre8 reservoir are so well preserved from the injury. This can lead to a very well-preserved curve of drug release into the coronary vessel, probably leads to a very less adverse event in the follow-up. So we use, in this case, Cre8 EVO. And through the guiding catheter extension 5 French, we deliver at Cre8 EVO 213 at the crux, and at 33 in the proximal part, and at 3.526 at the ostium. After that, we perform an injection. We had not so good result in the mid part. We post-dilate with 2.5, 3.25, 3.25, and 3.75 all along the stent that we implanted. And this was the results after the post-dilation. We have TIMI-flow 0 on the right, and we need to do something more. At this point, we do the re-engagement of 5 French guiding catheter extension with the technique that we call distal anchoring. We advance a 2.5 balloon distally. We inflate the balloon over there, and then we advance, we push the guiding catheter extension up to the distal part of the right, and then we implant another 2.5 33 stent between the two stents already implanted, and post-dilated with a 2.75. Pot on the 4 with the 4 on the ostium on the right, and this is the final results. This is the LAD, and this is the right. So our experience on the use of a Cre8 EVO is start 4 years ago. We perform almost 300 PCI with using a guided catheter extension 5 and 5, 6 French. We deliver more than 400 DS through the guiding catheter extension, and the main reason for the use is the very high tortuosity, the highly calcified lesion not reachable by a balloon or devices, and the lack of guiding catheter backup support. The data are emerging, and we have the results well aligned with the primary hypothesis that we have, but we present this case in the future. The conclusion are the very complex case should be approached without increasing the risk of vascular complication with large sheath, large guiding catheter, femoral access devices. The knowledge of materials such as dedicated wires, microcatheters, guiding catheter extension is crucial in order to perform a successful PCI. And in order to maximize the clinical outcome of the complex PCI involving the use of guiding catheter extension, we need to deep dive the impact of the surface abrasion damage that Cre8 seems not to have on the long-term follow-up. Thank you.
So if the operator was started before starting the procedure, I can imagine at the end. So to be honest, Salvatore, I need to thank you because this is for me an eye-opening presentation. I never thought first. Second, heard about the fact that different stent type can matter in terms of degree of damage on the stent in itself by delivering them through a guiding catheter extension. So I never thought about this. So I'm really thoughtful and thankful, more than thoughtful to you. By raise of hand, who has ever thought about I need to select my stent carefully because I have a guiding catheter extension now? By raise of hand.
No one.
I did. Okay, some of them did. Can you share with us what are your thoughts on this and whether you have selected one stent versus the other and why?
It depends on what kind of material you have in your room, and try to get. We use a lot of the zero platform. I don't know if you have it. Depends on what you have in your room. You use a lot of the zero platform. I don't know you have enough experience with that one. That's the one that we try to use when you use the guiding extension.
Okay, but or Cyro, whatever you want to pronounce it, because of the stent thickness in itself.
Yes.
Not because of polymer/coverage,
No,
which is what led Salvatore to use this stent, because there is no polymer, no drag.
Yes.
The polymer is inside the stent, and basically there is nothing in the upper surface of the stent, which is something I never thought about before. So I'm really. Do you have data about Orsiro, Salvatore? Did you compare yourself with Orsiro?
We have some data, but it's incomplete, and we have to publish it in the next future. But we are continuing the follow-up of this patient, and in the next future we can present our results.
It's a great point.
One more thought to the stent polymer damage. This not only happens when you shove it through a guide extension catheter. This is the same when the vessel is tortuous and there are spikes, especially calcified spikes, and you apply a large amount of force when you try to get your stent down to your lesion of interest. The same thing happens to the polymer, as we've seen with your extremely nice magnified images. So also bear in mind that this is not only the guide extension catheter, it's when you try to shove it through a tortuous primary lesion, this also happens.
Yes.
So when the stent reaches your distal portion, about 25% of the drug is lost.
Yeah, you lost 25% of the polymer just across the guiding catheter extension. So we know that when we push a stent along the very calcified lesion, with some damage on the stent, we have for sure. But we had the damage on the stent even with the easily crossing into the guiding catheter extension. We never know. We never thought probably in the past, but we have data on that now.
Wonderful. Thank you very much, Salvatore. I think it's going to be an emerging topic for research. And now, last but not least, Dr. Mosley, who is a great operator. I'm sure he will entertain us and teach us a lot of things.
Marco, thank you very much. And thank you once again for the kind invitation. So I've been tasked to share with you a very calcified lesion. This is a 60-year-old lady, not very long ago, and her symptoms worsened in January of 2024 in class 2. She flew all the way to see me from the east to West Malaysia across the sea after she had a coronary angiogram that showed left main stem and triple vessel disease, and she didn't want any surgery. Diabetes, hypertension, dyslipidemia since 2005, and a strong family history of coronary artery disease. The ECG was nothing much, but the echo showed that the LV function was 40% with suggestion of infarction in the distal or main LED and also the distal RCA. Bloods showed that the diabetes and cholesterol was not well controlled, and the EGFR was, the urinal function was normal. And this is the diagnostic angiogram that was done in her hospital that she was staying in or staying close to. And you can see that I tried to mark the calcification and seen in the right coronary artery with severe stenosis in the mid of the right. And this is the calcification that's seen in left main stem, LED, and circumflex. And you can see severe stenosis in the distal circumflex, proximal circ, and in fact, proximal LED, and in fact the LED lesion extends until the mid, And there you can see the severe stenosis. And I look at it, it's a Medina 111. So the question is, how would you treat these lesions? Which to be treated first? Are we going to do all at one go? And if it's so, then the left side or the right side first? Imaging, I think, would be required, but so what's your choice, IVC or OCT? How do you prepare the vessels, or especially the calcified lesions? And, of course, lastly, the stenting strategy for the left main stem.
Thank you very much. Let's open it for discussion. If you have comments, Professor Han in Korea. Cabbage does not exist, so it's okay. We can ask.
Yeah, this is a very tough case. I would like to treat left main first. Probably one stent cross strategy at first, and after that I will treat RCA if patients tolerate the left main PCI. And I choose the IVUS in this case because the left main itself has some disease. I don't need the physiologic testing, but after left main stenting, we can consider FFI for left circumflex. In the first, I do ballooning, but the balloon response is inadequate. I will do rotational atherectomy.
Thank you. And Salvatore, you would go for a 4 French guiding catheter PCI? No.
Well, my comment is the same almost of the one before. This is a very 111 Medina classification for the left main, and probably for me the imaging is mandatory, and I perform probably the IVUS, and after the IVUS I would choose which are the device or balloon preparation of this lesion. Probably in considering the diameter, the size of this vessel, I would choose or the shockwave or the orbital atherectomy in this case, because probably the rotational atherectomy, even the largest burr, is not good to have a very good preparation in this case. And for the strategy of how to treat, I am so confident with the Collot technique. So probably, even in this case, if the ostium of the circ was involved, probably I perform a Collot technique.
The left or the right first?
Sorry?
The left or the right first?
Left to right first. The right RCA, the coronary artery, or the right coronary artery, or the left coronary artery? Would you treat first?
Would you treat? I treat probably. I start with the left, because I would like to fix the most important and prognostic lesion, and then I move to the right, even in an elective procedure during the same admission of the patient. But I start with the left.
Okay.
I would start with the right, because it gives you a parachute for the left system, because the left system requires some work. Go ahead and show us what
I love my co, because we are so aligned in a number of instances. So she had financial issues. Obviously, we're going to try and see whether we can treat all the lesions first. I thought that we are going to treat the right first, again, because the LV function is only about 40%. The left appeared so complex. And I thought the right was a bit easier to be treated. I wanted to image with IVUS, and because of financial issues, we said we're going to try with scoring in NC balloons and see how we can how well we can achieve results. And it's through a transradial route. So a 7 French. And you can see that after a period of 6 weeks, the lesion had progressed much more than what she presented with. So we knew that I don't think we could get the IVUS catheter down, so we dilated with a 2.0. And roughly this is after 2.0. And you can see that the calcification, yes, it is calcified, but it is not as bad as what I thought it's going to be. Let me just run. And it's not more than 180 degrees. It's fairly superficial. But towards the end, and this is where I stop, this is where the calcium nodule is, just right there. So it actually impeded our devices subsequently. So what we did was we actively engaged, and this has been described by Salvatore. and a Guide Plus 2 extension guide catheter, and that helped us to actually get this subsequent balloon down. We could not get the NSC alpha balloon to go down initially, but with the extension guide, this was able to be delivered. We went at high pressures, and it looks full. We then decided to implant a Cre8 EVO stent after a 3.5 NC balloon, and that was at 28 atmospheres, and it was full. Why Cre8 EVO? I think because, again, she has diabetes not well controlled, and the markers would help us, especially with regards to treating the ostium. So one stent and another stent, and that covered until the ostium. So we then post-dilated with a 4.0 and a 3.75 towards the distal end, and we find that this is the results. And that's the result again. So you can see that the CSA is 10.2. There was still the calcium nodule that we see, but the CSA is 10.0 mm squared, and I therefore accepted these results. Now, looking at then reanalyzing back the angiogram, we thought that the left main stem, I don't think I'll get a good result with just balloon and stents. So we decided to do an atherectomy device. So we managed to pass an IVUS, and you can see that significant lesion in the distal left main stem, and even until here where the tightest lesion is about 1.5 mm squared. In this case, I chose an orbital atherectomy system because the blood vessel is big, and I want to try to debulk as much as possible. So we went down until the point where it was normal. Now, one of the things that you see is that we have actually created an aneurysm, and this is quite well known. I went low run at 80,000 and pulled back at 180,000, and that may have actually caused the aneurysm. You can see the aneurysm at this point in time was only 5. You can see the reverberation here that suggests that you have actually cracked or fractured deep calcium. So now, whilst doing that, the flow inside the circumflex to the circumflex was affected. I had difficulty. I could not wire into the circumflex. I used a supracross 120 degrees. Still, I could not get it, even though it was pointing to the circumflex. So in the end, we were able to cross using a double lumen catheter and using a filter XT wire, and to try to cross it. And that usually does a trick. Change it with the OS Viper wire, and did OS at low speed. So in a place where there's a lot of bend, you may not want to do high speed with OS because, again, the aneurysm risk is much higher. So dilated with 3.25, you can see the results. It looks quite good. Just note the aneurysm here. Then use the same NSC aperta scoring balloon. Also dilated the circumflex at the same time, and that was results at least in LED before. You can see that the branches are still well preserved. I decided to use the drug-coated balloon for the mid-LED just to reduce the amount of metal that will be in the LED. So the first one was a sequence please 3.0 by 40. And then use another sequence please in the circumflex. So thinking of provisional stenting across the left main to LED. That was with a 3.5 by 40. Then stented with Cre8 EVO again, using the markers to help us, and to implant it just, actually it's just inside the aneurysm. And this is what you get in the end. So pot with 4.5, went high pressure with 4 because at around the ostium LED was about 4.2 mm vessel diameter. Did a kissing 4.0 and 3.25, final pot, repot at 4.5, and this is what we had. So I did not show a picture, but we then again went with an IVUS. There was about 2 mm portion at the distal end of the aneurysm where it was actually aneurysmal before it came back to about 4. So use a pot balloon is a 6 mm, and it's a very short, the shortest that we have for non-compliant balloon. 14 in the LED, left main stem at 20, and then that's the results after. So you can see the results, the aneurysm, and I'll just show you the IVUS, and you can see the calcification. This is distal to the stent, this is where the drug-coated balloon in, and this is where the stent in, you will not be able to match or rather get the stent to be opposed to the wall, because it's about 6, and you shouldn't try, because if you have a fairly straight, then you don't have the flow will be fairly linear. But if you have something which is like open up, then the flow will be a lot of eddy currents around it, and the risk of thrombosis may actually be much higher. So in the end, the results were quite good. We accepted this. And this is summary procedure, right? Scoring stenting, IVUS guide, left main stem LED, OOS, CIRC, DCB, a single stent crossover, and also DCB, we had an aneurysm in the proximal LED, but in the end, results was good. I'm pleased to inform you that she's well. She came back just 2 weeks ago. She almost had to mortgage her houses, so she was thankful that she managed with the finance, but everything was fine in the end. I hope it will last her for a long time. So to summarize, with calcified lesions, it still poses a challenge treatment. Decision making can still be difficult. Even at this point in time, we're thinking what is the best form of device that we should use. But obviously, with any form of calcified lesion preparation is very important. The use of appropriate devices for plaque modification. Suboptimal results is something you want to to avoid, because of risk of stent thrombosis and future ISR. And in this case, hybrid and blended DS and DCB, I feel helps to reduce the amount of metal use, especially in complex lesions. Thank you very much.
That is probably very complex among the complex cases that we discussed. And a comment I would like to start with that I forgot to mention for you, Salvatore, is that it's a wonderful case that illustrates how the CTO knowledge and armamentarium can help us out during a non-CTO procedure, right? Use the SUO wire, which is not very frequently used outside the CTO. You use dual lumen cross, sync catheter, super croc, fielder XT. So this is normally armamentarium that we use for a CTO PCI. So I want to discuss with you, and I'm gonna engage you as well in the discussion because you mentioned this, how to modify the plaque in such a severely calcified disease. You did not use any plaque modification technique for the RCA, which I would have done. That for me was a rotablator case, but you managed because our final result is wonderful, and see cross-section area is 11, so it's more than enough. But I want to discuss the left with you, and especially because I'm not a fan of orbital atherectomy. Actually, I never use it. I'm only using rota in here. I would have done rota plus lithotripsy for this distal left main. Use orbital atherectomy, and you ended up with a big aneurysm. So helping understand what did what in this case.
Yeah. I think the choice of OS, because it can debulk much bigger with one device. So if rotablator, then it's going to be a small, or rather the size that you use, and then you've got to use a lithotripsy. So lithotripsy will add on to cost, and it's quite costly. Lithotripsy it's almost like double the cost for rotablator. So, and that was a choice. Aneurysm has been known to occur in OS, especially if you use high speed, and also if it comes across a bend. So that's quite usual. But most times are not. They either remain the same or actually they heal. So unfortunately, I think because I try to debulk as much as I can, I went low speed, and as I pull back, I went high speed. So maybe that increases the risk of aneurysm. But the choice is because financial choice, and also the fact that you can use one device.
Thank you for this honest answer, Professor Han.
Yeah, I understand the hybrid approach of DCB and DS, but in left main lesions, I usually implant the DS. So in this case, if I were an operator, I implant another Cre8 EVO in the left main to CIRC. So I'm not sure that the DCB in the left main or large vessels.
Yeah.
So probably you prolongation ballooning time was 1 minute or?
Yeah, firstly, in left mains, at this point, you should not put the DCB in. That's the reason why it's stented. But the ostial circ is something that you may want to consider. And, the stent the balloon is just into the left main. And the left main balloon the circ balloon is definitely smaller than the left main. So the flow is still all right, firstly. Secondly, I feel that the provisional stent, in the case, if you look at it, the actual severe stenosis was actually fairly short. It's just that there was some other lesions distally, that's why it was a longer balloon. But a provisional stenting, to me, less metal is always good. And if the circ comes back, it's more difficult to treat. And that was the reason. At least we give a chance for this patient.
So we discussed the fact that each stent may not be alike when being delivered through a guiding catheter. Now we are discussing plaque modification techniques for calcium, and I would like to ask you now whether you would think that the same principle may apply to EVL, to lithotripsy, because when we are losing lithotripsy after stent implantation, which is sometimes a bailout technique, which is frequently used despite being off-label as far as I know, but yet we can crack at that moment the stent polymer and deliver the drug, release the drug so quickly. Can you comment upon it?
Yeah, I think in this case, because it's calcium nodule, but the CSA is quite large, so that's why I accepted the end result is quite good. But if we do get this, the stent is not well expanded. I think definitely one of the ways to treat is with lithotripsy. Now the question will be that how does it affect the stents? And there was a study from Australia showing that you go and use lithotripsy in a polymer-based stent, you can actually cause cracking of the stent and that cracking of the polymer, and that may affect drug elution. Whereas on the other hand, if you use Cre8 EVO, there is no polymer, then obviously this does not happen. So I think that's a point that you may want to consider.
Wonderful. Thank you very much. We are getting close to the end. I'm going to skip my slides because I would like to make a few highlights here without using slides. The first highlight is that we did not perhaps discuss that extensively, but again, I would like to remind myself and the audience that Cre8 EVO is, as far as I know, the only stent which has superior outcome to another contemporary DS in diabetic patients. And in fact, we have 3 complex PCI patient with diabetes, and in all 3 cases they all receive Cre8 EVO. That is probably the rationale. The second comment would be that I at least learned a lot about the fact that not every stent type may be alike when being used in a severely calcified vessel, because of guiding catheter extension need for delivery. Second, because of IVL after stent implantation is an option. Last but not least, the geometry and the engineer component of the stent, of course, make the stent very suitable for complex anatomy such as left main bifurcation or any other bifurcation. With that said, I would like to thank the speakers for having given a very wonderful presentation, our chat master, and for the audience for having been so shy, but at least next time you can ask your question. Thank you very much.